I'm Anthony Leeds, and it's my pleasure to welcome you to this episode in which we're going to discuss surgery for obesity. This is a very important topic when we consider that across the globe as a whole, there are well over 650 million people who are obese, and there are vastly greater numbers who also have overweight and some of the other comorbidities associated with obesity. It's my pleasure to welcome my guest this week, Mr Pratik Sufi, the senior bariatric surgeon from the Whittington Hospital. Thank you very much, Sufi, for joining us today. Perhaps what we should begin with is a consideration of what exactly is done when surgery is undertaken for obesity, and how does it actually work? What are the mechanisms? And I know there are different types of surgery as well, of course, so perhaps we could begin by saying what is surgery for obesity?
Hi, Tony. Good afternoon. Well, thank you very much for this very nice introduction, kind introduction. So bariatric surgery has been around for over 3 decades now and has got a very strong history of helping people to lose weight who have tried other methods to lose weight and haven't quite succeeded. So briefly, there are 3 main types of operations. One are restrictive operations, which restrict the capacity of a person to eat, whether by introducing some sort of restriction to entry of food into the stomach, or perhaps restricting the amount that can be fitted in the stomach, or changing the size of the stomach. But these are all restrictive operations. And then there are operations that work by malabsorption, which does not change the amount that you can eat necessarily, but introduces a malabsorption, by which I mean that people cannot absorb all the nutrients in the food. Therefore, they can eat a larger amount of calories, but still lose weight till they reach an equilibrium. And then there are a third type of operations which are in between. We call them diversionary operations, which will divert the food. And it's not entirely malabsorptive. There is an element of malabsorption, but that is not predominant, and it is mainly the food being diverted, which causes patients to be less hungry. And the aim, of course, with all of these operations is to introduce some sort of restriction, some sort of hunger control, and of course, perhaps a bit of malabsorption in operations that are designed to do so. Does that answer your question?
What sort of weight losses do people achieve with these types of surgery?
Assuming that they comply, which the vast majority do, about 80–85% patients do manage to do so. And then the weight loss can range from, if you're talking about excess weight, we talk about something like 50% to 80% of their excess weight. But if you talk about the total weight, then the total weight loss would be less than that. Obviously, if someone loses 80% of their total weight, then there will be very little left of that person. Yeah. So we're talking probably about losing about 40% of their total weight in the operations that are designed to lose more weight, which is more than sufficient in case a person is about 150 kg. And then if you're looking at that person losing about 60 kg, then that person will become 90 kg. And that sort of gives us a very nice weight to go by.
Mm-hmm. Many of the people who are eligible for bariatric surgery, for obesity surgery, have other conditions, don't they? So they may well have diabetes and osteoarthritis, high blood pressure, etc. And indeed, the criteria that are set and written out in most countries actually do specify that there has to be another comorbidity, doesn't it?
Yes, but that probably is more because of resources that we have got. There are 3 types of resources that we're talking about here. First of all is having the hospital capacity. And if we started operating on all patients for excess weight who can't control their weight with their diet and lifestyle alone, then we will run out of hospital beds. Because, as you know, in countries like United Kingdom, being normal weight is a minority profession. Most people are actually overweight. Then we're talking about the number of surgeons that are available to offer the service, and that is severely restricted. And finally, of course, the resources that we've got, the money and the national resources that we can allocate. So that is why we have to be careful as to how we do it, so that we can provide an overall holistic service for everyone, because we have to look after patients with other conditions as well in that same budget. So there are some well-established criteria. So most patients, we would expect them to have one or more of these health issues. Commonly, for men and women both, diabetes is very common. And we're talking mainly type 2 diabetes, though type 1 diabetics are also eligible. Then we're talking about blood pressure and other conditions which is recognized as part of metabolic syndrome. And that also includes things like obstructive sleep apnea. In women, specifically polycystic ovary infertility, which is due to hormonal imbalance and estrogen excess, and patients who are presenting with difficulty in moving around because of arthritis. Maybe they need an operation, a knee or a hip replacement, but that cannot be done until their weight reduces below a certain level. So arthritis is a very common indication nowadays to do these operations, and a lot of the time just operating and losing the weight can help these people avoid a hip replacement or knee replacement for a good many more years. And then there are conditions where patients are infertile. Women are infertile and they're looking for fertility treatment, and there is a criteria. Patients with a BMI above 30 at the moment is not funded for this type of treatment. And then there are other indications. So we do it for other reasons. So some patients may present with, for example, benign intracranial hypertension. Again, a well-recognized condition where we do it. And sometimes patients require maybe an abdominal wall hernia repair, but the surgeons are reluctant to operate. Someone has got a hiatus hernia presenting with heartburn and indigestion. And again, if the underlying problem is obesity, then that needs to be resolved and sorted. And if a patient has tried and struggled to lose the required weight with diet and exercise alone, or nowadays, as we know, there are some medications as well, then bariatric surgery is a good way to help people achieve that target.
Yeah. And in terms of the benefits that occur as a consequence of the weight loss, they're very clear, aren't they, in terms, for example, of the health economics calculation, in terms of the cost benefit, in terms of, for example, if we consider diabetes as the example.
Yes, absolutely. Absolutely. I mean, let's say that on average in a healthcare system like UK, if it costs the healthcare system £10,000 for an operation, but if you look at the amount that the healthcare system would spend on the anti-diabetic medication, the testing, the treatment of complications, and knowing that these diabetic patients will go on to develop renal problem, eye problem, nerve problems. So it is very well established that bariatric surgery pays back the amount that is spent within a few years, really 3 to 4 years. It pays back the money that is spent on these patients. So it is cost effective, there's no doubt about it.
Are the criteria for being acceptable for bariatric surgery the same across the world, or do they vary? We have to bear in mind, of course, our audience is a global audience, but particularly the viewers are watching from South Asia and East Asia and Southeast Asia?
So yes, that's very interesting. So it depends on the resources that are available, and the criteria can be also dependent on whether the resource allocation is taking place in a public health system or in a private healthcare system. So in private healthcare system, generally it is different. So let's talk about the public healthcare system. So worldwide, generally, patients would be eligible for bariatric surgery if their BMI, and by BMI I mean a body mass index, which is a measure of an excess weight generally. This is not the only measure and not necessarily the best measure, but this is the easiest measure. The other measure, of course, is the waist circumference, but that can be a bit more cumbersome to handle. So the BMI is an easy way and applies for most patients. General BMI, we expect a person to be between 18 to 25. So below 18 is underweight, above 25 is overweight, and therefore if a person is BMI 50 plus, then in all healthcare system they would be eligible for bariatric surgery even if they did not have any other health issues.
Yeah.
If, however, they are between BMI 40 and 50, then they would be eligible for bariatric surgery if they have tried to lose weight with diet and exercise or nowadays medication and failed to maintain that weight loss. Once again, the challenge is not about losing the weight. The challenge is about losing the weight and keeping the weight off long term. So we know that everyone can lose weight for 6 months, but we're not talking about losing weight for 6 months. We want people to lose weight for 6 years, 16 years, 26 years if we can. And that is where bariatric surgery has a really great role to play. As far as patients between BMI 35 and 40 is concerned, remembering again that 25 is the upper limit of normal BMI for most patients. For subcontinental people like us, myself included, our BMI probably is upper limit is probably 23, 24. At 25, we are already starting to show signs of excess body fat in our waist. And that's the waist circumference is very important. And people of the Southeast ethnicity, Southeast Asian ethnicity, we have a tendency to have more bad fat, let's put it in that term, in our waist and our surrounding our viscera, our organs, inside our belly, surrounding the kidney, the intestines, the liver. And we know that these patients will do worse if they put on weight. So we offer these patients surgery for a little lower BMI, but general for 35 to 40 with any of those comorbidities that I've mentioned. And we know that if these people lose weight, then the risk of other risks also improve. For example, their cancer risk goes down by about 2 to 3 times, really. So that there is a great improvement in those risks as well. Now, below BMI 35, if they are diabetics, then they are certainly considered from BMI 30 onwards. If they have had diabetes, and previously we used to see patients who come to us with more late diabetes, having tried everything else for 8 years, 10 years, and the diabetic control is getting poor. They're about to go on to insulin, and that's when they were being referred. But the paradigm has shifted, and the current general advice is, excuse me, if someone needs an operation, then probably they would get the best results if they are having their operation within the first 2 years of developing diabetes, because then the resolution of the diabetes is for a longer period.
And that would tie in quite nicely with the results from the dietary study in Glasgow and Newcastle, where they've observed that the people who were diagnosed most recently, rather than those who, for example, have had a diagnosis of up to 6 years, the ones with the shortest period are the ones who are most likely to get a good outcome. So it's consistent, isn't it?
Yes, yes, because the diabetes is due to the sort of prolonged excess of the sugar and fat that our body is trying to process, and in the process our body starts running out of the enzyme, the hormones, that help to control our blood sugar, the insulin, and so the pancreas starts to run out of its reserves, and therefore if that intervention can be done before the reserves start running out, and the diabetic control is achieved, and then of course the patients develop a good lifestyle, then the benefits are better than for someone who has already depleted the reserves, and therefore they would also benefit, even those who have sort of depleted the reserves and let's say they're on insulin. So it is a great improvement if someone is on insulin and can come off insulin and is just on metformin or one of the other anti-diabetic medication, or perhaps someone takes 160 units of insulin. If that person can come down to 20 units, 30 units of insulin, then that's a great improvement. So there is no doubt about it. But the earlier the intervention, the better it is. And then,
sorry, you also mentioned that in Britain we see some very heavy people with BMIs of 40, 50, even 60 sometimes, and even greater.
70 BMI.
And they represent quite
you and I have been involved with people with BMI almost 80, I think. Remember, we have seen patients like this. So yes, patients with high BMI, 75, 80 is not also unknown.
But they're a challenge for the surgeon and the anaesthetist, aren't they?
Yes, but compared to what we were faced, let's say 20 years ago, the situation has moved on. So we have now got diet options, medication, in-between options like balloons. So there are many things that we can do to try and get 40, 50, 60 kilograms off from these patients, so that they can then become safer candidates for surgery. But I think that the goal for us long term in the health system should be that we should never end up with patients reaching this sort of BMIs. I think it is an indictment of our health system that we allow patients to reach this stage before intervention. But I think there is a much greater awareness now, and therefore it is more likely that patients would seek help, and more likely that doctors would pick up rather than allowing patients to become BMI 65, 70, 80, which is a challenge to manage.
So you mentioned there dietary interventions and other interventions which can achieve weight loss before surgery. One of the main purposes of that, of course, is to reduce liver fat and liver volume, isn't it, to make the procedure a little bit easier. Do you want to comment on that?
That's for bariatric surgery, yes, but generally the metabolism of the body would improve, and the inflammatory state of the body would improve if we can reduce the excess fat and sugar that is being carried around in the body. So, but for the operation itself, diet is important. The liver shrinkage diet that we're talking about, to try and reduce the amount of liver that is in amount of fat that is in the liver, so that the operation is less challenging, less likelihood of bleeding and trauma, and less likelihood of a prolonged recovery.
Another interesting question is the difference between different countries in the amount of surgery that they provide. Now, some of the figures I've seen suggest that, for example, in the Czech Republic or in Sweden, the numbers of surgical procedures done per year is up to 9 times higher than, say, it is for the United Kingdom. And you mentioned resources earlier on, but obviously in those countries the calculation is done to show that there's going to be long-term health cost reductions, but we don't seem to do that in the UK. What would you like to see happen here in the UK?
Yeah, I mean, this year in BOMS, we're talking about this, that in the UK, the public health system has operated on 4,000 patients this year, which is a drop in the ocean. Turkey has operated on 8,000 of our patients. So let's say that another 8,000 has been operated on the other parts of the world. So all in all, we are probably getting around now 40,000 patients who are going and having bariatric surgery in the United Kingdom, which is really nowhere near the numbers that we require in order to see a sustained benefit. So let's talk about just diabetes. So diabetes consumes a huge chunk of the NHS resources at the moment. And if these patients who are currently on their way to become diabetic, if these patients could be managed such that they don't develop diabetes for another 15, 20 years, or perhaps never develop diabetes, then that would be a great sort of lessening of the strain on the health system. So yes, sadly, we have got in this country, the public health system is decided by the politicians, and the politicians have got a 4-year sort of cycle. So they can only see 4 years ahead and not more than that. Anything that is 8 years, 12 years is not in the horizon, because they don't think that they necessarily will be there. So 20 years, 30 years down the line, they find it difficult to see. But in an ideal world, the NHS would, or a health system would look for benefits that they would achieve over a period of 20, 30 years rather than the next 4 years.
I mean, I think also that probably we need a more integrated approach to weight-related problems as a whole. So an ideal situation might well be to have, for example, specialist GP hubs where there are general practitioners who are particularly focused on metabolic medicine and obesity management, who can then work and be very closely associated with all of the different types of interventions that are possible, dietary ones, specialist dietary ones, like the current, for example, rollout of a diet program for diabetes remission, which hopefully will take some of the people who are either going to develop diabetes or have just got a diagnosis of diabetes. That is now being rolled out by NHS England and NHS Scotland, which is very good. But I think there are quite a few more steps to go to getting everything as we would all like to see it, as we would like to have. We've all discussed this over many, many years, and we would all have wished that this would have happened some time ago, but it would be better to move towards a sort of integrated system, I think.
Yes, I agree. I mean, in an ideal world, a lot of the problems can be sorted out at an earlier stage, and not even at a stage where patients become patients. People become patients. In an ideal integrated system, we would address this problem from school. So we'll be looking at the food that is available to the children in school, what sort of health education they have, and understanding they have, why they have barriers to good nutrition, and improve those things. We know that there is a huge amount of health inequality in the world, not only in this country, but in other countries as well. So people coming from immigrant backgrounds, minority backgrounds, people who do not necessarily know how to access the healthcare system, end up not benefiting from the other measures that are out there to help and to prevent this problem happening. So yes, it is. I think it will be lovely if we can start designing from school. I mean, we would need more playgrounds so that children can play, more physical activity, less processed food, less fast food joints around the schools, colleges and universities, more time to be able to enjoy a nutritious meal rather than rushing to eat processed food like crisps, chocolates, etc.
Yes.
All these things included.
Now, yeah, there are some cities in the United Kingdom where quite good efforts and achievements have been made in, for example, limiting the availability of fast foods around the schools and so on. So it is being done in some places, but perhaps not everywhere. So actually, in a sense, that would be a good point at which we should pause for this week's discussion, because there are other things we need to talk about. And next week we can cover interesting questions like the evidence for the long-term benefits, and also whether people who've had surgery need to consider special things like whether they need to take some supplements. We'll discuss those next week. But Pratik Sufi at the Whittington Hospital, thank you very much for talking to us this week. Thank you.
Thank you, Tony. Thank you, Tony.